Okay, let's get into this. We're focusing on a particular state of varicella-zoster virus reactivation. We aren't talking about your standard shingles, the one with the classic rash.
Right.
No, this is about VZV reactivation pain. It looks like zoster, it feels like it, but, and this is the big thing, there's just no rash.
And that lack of a rash changes everything. Our goal today is, well, first, defining Zoster Sine Herpete.
Okay.
And maybe more importantly, outlining the lab steps you absolutely have to take to confirm it.
Right, the non-negotiables.
Exactly.
Let's start right there. Definition. If a patient has VZV reactivating but zero vesicles, what do we actually call that?
The accepted term is Zoster Sine Herpete, often abbreviated ZSH.
ZSH, got it.
It means VZV reactivation, but presenting only with that nerve pain along a dermatome. No skin eruption.
So no blisters.
None. And it's that lack of the defining rash that sets it apart from typical herpes zoster.
Right. So how does this patient actually show up, clinically speaking? Because without those skin signs, they could walk in complaining about almost anything musculoskeletal, right?
Absolutely. The clinical picture is tough because it's purely a pain syndrome. Patients come in with acute, pretty severe, one-sided radicular pain.
Radicular, so nerve root pain.
Yes. They might describe it as, burning, maybe electric shocks, sometimes like lightning bolts. It's intense pain.
And you mentioned radicular pain, implying that nerve root. Can you expand a bit on other symptoms they might report along with the pain?
Sure. Besides the severe pain, they often mention paresthesias, that's abnormal tingling or numbness. Or they might have dysesthesias, which are distorted sensations, often painful just from light touch in that skin area.
Okay.
And critically, it's almost always strictly confined to a single dermatome. That pattern is the big clinical clue. This is a nerve issue, not muscles or joints.
That specific agonizing band of pain. Yeah, that should raise suspicion. But like you said, no rash. So maybe it gets put behind, I don't know, a herniated disc or a muscle strain in the initial thought process. Why is getting this diagnosis early so important?
It's vital because the underlying problem is exactly the same as classic shingles. You've got active virus multiplying in the dorsal root ganglion.
Okay.
So missing ZSH means you delay antivirals or maybe don't start them at all. And that delay dramatically ups the risk for serious complications, especially postherpetic neuralgia, chronic pain.
Right, the PHN. Okay, so since the clinical picture can be misleading, diagnosis really hinges entirely on the lab work confirming VZV is reactivating. How do we kick off that process? What's the best test for speed and sensitivity?
You have to go for nucleic acid amplification tests first, specifically VZV polymerase chain reaction, PCR. It's the quickest and most sensitive way to detect the active virus. Ideally, you'd test cerebrospinal fluid, the CSF.
CSF, okay.
But blood samples can sometimes be used too. It depends a bit on how the patient presents.
And the turnaround time on that. How quickly can we expect PCR results back?
Usually PCR results are quite fast. You're typically looking at 24 to 48 hours.
Okay, 1 to 2 days.
That speed is really key for starting antiviral treatment when it counts the most.
That speed is definitely a plus, especially with a patient in acute pain. But VZV PCR, it has a known catch, right? A limitation related to timing.
Yes, that's a critical point. The limitation is how long the DNA hangs around.
Right.
VZV DNA might just not be detectable later in the disease course, say if you take the sample several days after the pain started. And also, if the patient has already started taking any antiviral medication, even before the diagnosis is nailed down, that can really drop the chances of detection. You could get a false negative.
So, okay, we have a test that's fast and sensitive, but maybe only for a short window.
Yeah.
What if we suspect it's been going on longer? Or we're worried about central nervous system involvement, like meningitis, perhaps. Is there a better test for that longer game, one that works even after the virus itself fades?
Yes, there is. For that, you need to test for intrathecal anti-VZV antibody synthesis.
Intrathecal antibodies. In the CSF again?
Correct, in the cerebrospinal fluid. Usually we're looking for IgG antibody.
IgG.
This test is vital because antibody production is actually much more sensitive over the long haul. It sticks around. It confirms the immune system fought off VZV specifically within the central nervous system, even after the viral DNA is gone and PCR can't find it anymore.
Hold on a second. If the patient comes in with what sounds like really bad nerve pain, maybe back or flank pain, and we're suggesting a lumbar puncture, a spinal tap, just to confirm a diagnosis that maybe could be something simpler like a muscle pull, that sounds like a pretty big hurdle. for diagnosis and for getting the patient on board. How do we justify that level of invasiveness?
That's a really important question. And the justification comes down to the differential diagnosis. What else could be causing this?
Okay.
You're balancing the invasiveness of an LP against the potential consequences of missing Zoster Sine Herpete. And those consequences can include lifelong debilitating postherpetic neuralgia.
So the risk of the complication outweighs the risk of the procedure.
Exactly. If your clinical suspicion is high, meaning acute, severe pain, strictly following a dermatome with no obvious mechanical cause, then the risk of the procedure is, well, it's far less than the risk of chronic pain from untreated ZSH.
That makes sense. That clarifies the rationale.
Yeah.
So this leads us to the best strategy overall for diagnosis. Given that each test has its own window and limitations, what's the recommended practice?
The highest accuracy approach. It requires using both tests.
Both, okay.
You should perform VZV PCR and test for intrathecal anti-VZV antibodies in the CSF at the same time, if possible. Yes, using them together really maximizes your chances of catching it. You get the acute infections with PCR and the subacute or CNS-involved ones with the antibodies. You really need both for the best yield.
Let's touch on something providers might try: standard blood serology. Looking at IgG or IgM levels in the serum, is that helpful at all for diagnosing acute ZSH?
No, absolutely not helpful for an acute diagnosis. Serum serology is basically non-contributory here.
Why not?
Because almost every adult already has persistent IgG antibodies just floating around in their blood, either from having chickenpox years ago or from vaccination.
Right, most people have been exposed.
Exactly. So a positive blood test only tells you they've encountered the virus sometime in their life. It gives you zero useful information about whether it's actively causing nerve root inflammation right now.
Okay, so serum tests are out for acute diagnosis. Good to clarify. Now, moving to management and complications. Since ZSH is basically the same process as regular shingles, just without the rash, what are the potential long-term issues we need to worry about?
It carries the exact same risks. The biggest concern, as we've mentioned, is postherpetic neuralgia, PHN. That can mean chronic, miserable pain for months or even years.
Debilitating pain, yeah.
And then, less commonly, but much more severe, are other neurological problems linked to VZV reactivation. Things like meningitis, encephalitis, or even transverse myelitis.
Serious CNS complications.
Yeah.
Okay, so if we manage to get the confirmation using PCR and antibodies from the CSF, what's the standard treatment?
Treatment involves the standard systemic antiviral drugs.
The usual suspects.
Yeah. Acyclovir, valacyclovir, or famciclovir. The management strategy is identical to treating classic herpes zoster. You're aiming to shut down viral replication as quickly as possible.
And timing is key, right? When exactly does that antiviral treatment need to start to be most effective? Is there a specific window we're racing against?
You need to start treatment as early as you possibly can after the symptoms begin.
How early is ideal?
Generally, the sooner the better, ideally within 72 hours of the pain starting.
The 3-day window.
Yes, that's the classic window. But treatment started even outside that window might still offer some benefit, particularly if you suspect any central nervous system involvement. But early treatment is really paramount for limiting the virus and reducing that risk of chronic pain later on. So the main takeaway here has to be, if you see a patient with severe dermatomal pain, but no Zoster Sine Herpete,
Right.
and to confirm that VZV reactivation, you need two specific tests from the CSF. VZV PCR and intrathecal anti-VZV antibody testing. Use them both. It maximizes your diagnostic certainty and minimizes the risk of PHN.